Just a reminder, this is lecture number 3 in the abdominal sonography series. So today we're going to go over the gallbladder. We're going to look at what the gallbladder is, some key terms, as well as certain pathology. So sonography is often the initial imaging modality of choice for the identification of biliary disease. So if you find patients who present with certain clinical signs and symptoms that are suggestive of biliary disease, then this is when we systematically examine our patients. So there's certain key terms, and like before, I'm going to go over each and every one of them. A calculus cholecystitis. This is inflammation of the bladder without associated gallstones. Acute cholecystitis is a sudden onset of gallbladder inflammation. Adenomyomatosis is a benign hyperplasia of the gallbladder wall. A biliary colic is a vein located in the right upper quadrant in the area of the gallbladder. Champagne sign, this is usually as a result of dirty shadowing, reverberation, or ring down artifact. This is caused by gas or gas bubbles produced by bacteria that are within the gallbladder wall. A cholecystectomy is a surgical removal of the gallbladder. Cholecystokinin is a hormone produced by the duodenum that causes the gallbladder to contract. Polydolithiasis, this is a gallstone in the biliary tree. Polylithiasis, also a gallstone. Cholesterolysis, this is a condition that results from a disturbance of cholesterol metabolism, and there's an accumulation of cholesterol, typically within a focal region of the gallbladder wall. And the sign we use in cases of cholesterolysis is a strawberry bladder. Chronic cholecystitis, this is cholecystitis that results from the intermittent obstruction of the cystic duct by gallstones. Chyme is partially digested food from the stomach. The stomach tail artifact, we talked about that previously, and it is a form of a reverberation artifact where there's a band of echoes that taper distal to a strong reflector. Courvoisier gallbladder, this is the clinical detection of an enlarged palpable gallbladder caused by biliary obstruction in the area of the pancreatic head, and it's typically caused by a pancreatic head mass. Crohn's disease is a chronic inflammatory bowel disease that leads to thickening and scarring of the bowel walls. The cystic duct connects the gallbladder to the common hepatic duct. Emphysematous is abnormal distension of an organ with air or gas. Empyema is the presence of collection of pus. Gallbladder torsion is a twisting of the vascular supply to the gallbladder. A Hartmann pouch is an out protein of the gallbladder neck. Hemolytic anemia is a condition that results in destruction of red blood cells. Hepatization of the gallbladder is a situation in which the gallbladder fills with tumefactive sludge. This causes the gallbladder to appear as a cloaked liver tissue. Hydrotic gallbladder is an enlarged gallbladder, and we refer to this as a mucus of the gallbladder. Hyperalimentation is IV administration of nutrients. Hyperplastic cholecystosis is a proliferative and degenerative gallbladder disorders. Hyperalbuminemia is abnormal low levels of albumin in the blood. Albumin is a protein produced in the liver. functional fold is a fold in the neck of the gallbladder. Kawasaki disease is a condition associated with vasculitis and can affect lymph nodes, skin, and mucous membranes. Leukocytosis is an elevated white blood cell count. Murphy sign is pain directly over the gallbladder when we apply probe pressure. Parity, the number of completed pregnancies that have reached viability. Pericholecystic fluid, fluid around the gallbladder. Peritonitis, inflammation of the peritoneal lining. A Phrygian cap, this is a gallbladder variant, where the gallbladder fundus is folded into itself. A porcelain gallbladder is calcification of all or part of the gallbladder wall. Postprandial is after a meal. Rokitansky-Askoff sinuses are tiny pockets within the gallbladder wall. Sepsis is a life-threatening condition caused by the body's response to a systemic infection. Sequelae, an illness resulting from another disease. Sickle cell disease, a form of hemolytic anemia, typically found in people of African descent. Spiral valves of Hester, these are folds located within the cystic duct that prevent it from collapsing. Or distending. Suppurative cholecystitis, this is a complication of acute cholecystitis characterized by pus accumulation within the gallbladder. Total perinatal nutrition is the feeding of a person intravenously. Tumefactive sludge is thick sludge. A wall echo shadow sign is shadowing from the gallbladder fossa produced by a gallbladder that is completely filled with gallstones. So we can move on to gallbladder anatomy. Now the gallbladder is located posteriorly to the right lobe of the liver, and the specific pouch in which we find the gallbladder is what we call the gallbladder fossa, and the gallbladder is considered an intraperitoneal organ. One of the useful landmarks to locate the gallbladder fossa is the main lobar fissure. The gallbladder is pear-shaped, and it stores and concentrates bile that is produced by the liver. It has three distinct layers within its walls. There's the mucosal layer, which is the innermost. Then we have the fibromuscular layer, and then we have the most outer serosal layer. The mucosal layer consists of multiple folds and rugae. The gallbladder has a neck, a body, and a fundus. The gallbladder neck is contiguous with the cystic duct, and this connects the gallbladder to the rest of the biliary system. The gallbladder connects directly to the common hepatic duct, and the portion of the biliary tree that lies distal to the union of the cystic duct with the hepatic duct is a common bile duct. The fundus is the most dependent portion of the gallbladder, and therefore is a common location for gallstones to collect. Blood supply to the gallbladder is via the cystic artery, and the cystic artery is a branch of the right hepatic artery. Chyme that leaves the stomach causes the hormone cholecystokinin to be released by the duodenum, and this causes the gallbladder to contract. So bile will then flow from the gallbladder into the cystic duct and then into the common bile duct. There are certain normal variations in the gallbladder shape. You can have a bilobed gallbladder, an hourglass appearance, a septated gallbladder, and this appears in multiple thin septations, a Phrygian cap, Hartmann pouch, or junctional hold. So how exactly do we scan the gallbladder? So as with a number of sonogram scans, we should always ask our patient to fast for a period of 4 to 8 hours. And when we finally locate the gallbladder, it normally appears anechoic, pear-shaped when we're scanning it sagittally. If we were to get a true transverse image of the gallbladder, we tend to get an anechoic circle. The size of the gallbladder is variable, but normal range is said to be between 8 to 10 centimeters in length, but no more than 4 to 5 centimeters in diameter. That is to say, lengthwise, this has to be about 8 to 10 centimeters, and widthwise, this is 4 to 5 centimeters. Some authors argue that gallbladder that measures over 4 centimeters in transverse, in this case, should involve scrutiny to check the signs of obstruction. So when we are scanning patients to evaluate the gallbladder, the patient is usually placed supine, or in certain cases left lateral decubitus. We can also see the gallbladder in prone or any other position to demonstrate mobility of any intraluminal objects such as polyps or gallstones. We employ intercostal imaging, especially if midline visualization is obstructed by overlying bowel gas. The gallbladder, neck, and fundus should be examined closely because they come on sites for gallstones to become lodged. The gallbladder wall can be focally or diffusely thickened, so this is the wall right here, and it should measure no more than 3 millimeters in thickness. There are certain cases where the gallbladder is not visualized, and the most obvious being a cholecystectomy. In patients who have had a recent cholecystectomy, there may be some residual fluid within the gallbladder fossa. So we can see the gallbladder here. So this is sagittal, this is transverse. Here we have the gallbladder, and next to it is the portal vein. And in this transverse, we have the liver and the gallbladder. Here's how it is. There's a cystic duct. We have the right and left hepatic ducts meeting the common hepatic duct. This becomes the common bile duct, and this would be the pancreatic duct coming here. So there are certain sources of diffuse gallbladder wall thickening, and can be after eating or postprandial. It can be during acute cholecystitis or chronic cholecystitis. We can have adenomyomatosis. We can have hepatitis or some other hepatic dysfunction like cirrhosis. We can have benign ascites, hyperalbuminemia. We can have AIDS, congestive heart failure, gallbladder carcinoma. These usually lead to diffuse gallbladder wall thickening. Focal gallbladder wall thickening comes from gallbladder polyps, also adenomyomatosis, carcinomas, and adhered gallstones. And causes of non-visualization include a cholecystectomy or a gallbladder completely filled with stones, and what we call the wall echo shadow sign. And in the wall echo shadow sign, the gallbladder is completely filled with stones and becomes very difficult to delineate from surrounding liver tissue. You can have a postprandial gallbladder that has been acted upon by cholecystokinin, and it has contracted and released bile, and so it shrinks. You can have chronic cholecystitis. You can have an ectopic gallbladder. There can even be cases of agenesis, or even a build-up of hemochromatosis sludge that leads to hepatization of the gallbladder. You can also have emphysematous gallbladder that is air-filled. So we can go over certain pathologies of the gallbladder. And first on our list is cholelithiasis. And these are biliary stones that form within the gallbladder. And they're usually composed of cholesterol, calcium carbonate, or calcium bilirubinate. Gallstones are commonly seen in female patients. Moreover, patients who are fat or flatulent, or female 4 and 40, and we refer to these as the 6 F's, and these are fat, female, fertile, flatulent, 4 and 40, have been shown to have a high incidence of gallstones. Gallstones have been found in children, newborns, and so on and so forth, and patients with Crohn's disease. So clinically, patients can be asymptomatic, but a biliary colic is often present. There can be abdominal pain after fatty meals. There can be nausea, vomiting, among other clinical findings. So sonographically, the cholelithiasis appears as a mobile echogenic structure within the gallstone lumen that produces an acoustic shadow. And remember, a gallbladder that would be completely filled with gallstones would exhibit the wall echo shadow sign. And in this situation, only the gallbladder wall and shadowing within the gallbladder fossa are observable. But in cases of the wall echo shadow sign, you can see tiny holes in the cystic duct going in the spiral bars of face. You can change the patient's position and alter the scan plane to resolve some of these dilemmas. We can have small gall stones that can adhere to the gallbladder, and these may not produce a well-defined acoustic shadow. There's also a twinkle artifact, which occurs posterior to a strong granular and irregular surface, like crystals or calcifications. And this may be used to differentiate adhered gallstones from gallbladder polyps. So, sonographic findings include echogenic mobile shadowing structures within the lumen of the gallbladder, and the stones can be lodged within the cystic duct or the neck of the gallbladder, and they may not move. And a wall echo shadow sign depicts a gallbladder that is completely filled with stones. So in these two images here, we have cholelithiasis with multiple shadowing, and echogenic gallstones are noted within this gallbladder. We have the wall echo shadow sign, so there's a gallbladder wall with an echo, and the shadow is completely filled. This is on a sonogram of the liver and the gallbladder fossa. And this denotes a gallbladder that is completely filled with gallstones. The gallbladder can have sludge, and we would say to a sludge causes hepatization of the gallbladder. But sludge within the gallbladder is most commonly associated with biliary stasis. Sludge may be found in patients who have coexisting gallstones or a gallbladder carcinoma. And in those suffering from jaundice, liver disease, hyperalimentation, or sepsis. In addition, patients who have undergone an extended period of fasting or on parenteral nutrition may also present with gallbladder sludge. Sludge is typically asymptomatic, and sonographically, sludge appears as a collection of low-level, non-shadowing dependent echoes within the gallbladder lumen. And whenever the sludge is visualized, we should closely evaluate the gallbladder for signs of gallstones or other markers of cholecystitis. Occasionally, sludge can then begin and mimic an intraluminal gallbladder mass. So when that happens, we refer to it as tumefactive. That is sludge that is thick and that is mimicking an intraluminal gallbladder mass. And the mobility of tumefactive sludge should be observed quite vigilantly. If we have sludge that does not move with the patient's position, we can suspect a solid mass may arrive, and thus color Doppler should be employed. Tumefactive sludge can also form into sludge balls. These are typically mobile and will not produce an acoustic shadow. By certain clinical findings, patients can be asymptomatic or have an extended period of fasting. So sonographically, sludge appears as a collection of low-level, non-shadowing dependent echoes within the gallbladder lumen. A good example is here, in the sagittal image of the gallbladder. It is layering sludge, and there is an echoic bile. The lipids over there. We can have tumefactive sludge completely filling the gallbladder lumen, causing hepatization, as you can see. The gallbladder is now isoechoic to the liver. Gallbladder polyps. A polyp is a projection of tissue from the gallbladder wall, and this protrudes into the lumen. We can have cholesterol polyps, and these are the most common kinds, and they tend to be small, measuring less than 10 millimeters. Cholesterol polyps are usually the result of accumulation of cholesterol and triglycerides within the gallbladder wall, and this thus causes an elevation in the gallbladder mucosal layer. Polyps may be solitary or multiple, and will appear sonographically as hypoechoic, non-shadowing and non-mobile projections of tissue. Although most polyps will have a stalk, the stalk might not necessarily always be seen. And gallbladder polyps typically yield the ball on the wall sign. And this is because the polyp appears to be a round object, and like a ball, it is stuck to the gallbladder wall. And so we refer to that as the ball on the wall sign. When we vary the patient's position, polyps will neither shadow nor will they move. It is important to remember most polyps are benign and incidentally discovered, although you can have a rapid growing polyp, and that might be worrisome for gallbladder carcinoma. Gallbladder polyps are often seen with cholesterolysis, and this can result from the disturbance in cholesterol metabolism and accumulation of cholesterol, typically within a focal region of the gallbladder wall. Cholesterolysis is considered a subset of hyperplastic cholecystosis, and it may also cause a diffuse polypoid appearance of the gallbladder, referred to as a strawberry gallbladder. I don't have an image of that here, although the strawberry gallbladder is not necessarily distinctly seen on imaging. Hyperplastic cholecystosis also includes adenomyomatosis. Clinically, these patients are usually asymptomatic. That is to say, patients with polyps do not present with any particularly identifiable signs. But sonographically, we would see hyperechoic, non-shadowing, non-mobile masses projecting from the gallbladder wall into the gallbladder lumen. And then this adjacent figure shows it quite well. Two polyps are noted attached to the interior wall of this gallbladder. We had talked about adenomyomatosis, and we had said this is one of the conditions of hyperplastic cholecystosis. The other form of that is cholesterolosis. Adenomyomatosis is interpreted as the condition of glands within the muscle of the gallbladder. And like cholesterolosis, it is a form of a hyperplastic cholecystosis of the gallbladder. With adenomyomatosis, the luminal epithelium is hyperplastic, and the muscular layer becomes thickened, and it produces the verticuli, or tiny pockets that we refer to as Rokitansky Aschoff sinuses. So we have talked about certain regions, or you can say divisions within the wall of the gallbladder. And we had said that the mucosal layer is the innermost layer, with the middle layer being the fibromuscular layer. The outer layer is the serosal layer. So adenomyomatosis is a condition arising from the fibromuscular layer of the gallbladder, and the reticuli protrude through the mucosal layer into the gallbladder lumen. And the muscular layer itself becomes thickened. And we talked about these Rokitansky-Aschoff sinuses. These sinuses may contain cholesterol crystals, and they may produce a comb-tail artifact. This is most often seen protruding into the gallbladder lumen from the interior wall. And adenomyomatosis can be focal or diffuse, and is often clinically silent. That is to say, there are no particular clinical findings that are distinct for patients who have adenomyomatosis. But sonographically, you see focal diffuse thickening of the gallbladder wall, as well as comb-tail artifacts. And that is quite well visualized here. The characteristic comb-tail artifact is over there, and it is produced by cholesterol crystals located in the Rokitansky-Aschoff sinuses of the interior gallbladder wall. Acute cholecystitis, which is a sudden onset of gallbladder inflammation, and it is referred to as acute cholecystitis. And the most common cause of acute cholecystitis is a gallstone. This gallstone has become lodged in the cystic duct, or in the neck of the gallbladder, and leukocytosis is often associated with acute cholecystitis. Other lab findings may include elevations in liver transaminases, ALP and ALT. Bilirubin may also be elevated. Besides patients presenting with right upper quadrant pain, epigastric pain, patients often complain of focal tenderness over the gallbladder. In cases of transducer pressure, when the gallbladder is inflamed, and we term this a positive sonographic Murphy sign. Other sonographic findings include gallstones, pericholecystic fluid, which would be fluid surrounding the gallbladder, sludge, thickening of the gallbladder wall, which will contain pockets of edematous fluid, creating this striated appearance. And when acute cholecystitis is suspected, we should first evaluate the gallbladder for progression to gangrenous cholecystitis or gallbladder perforation. So clinically, this patient would come over with some right upper quadrant tenderness, some epigastric or abdominal pain, some leukocytosis, some fever, pain that radiates to the shoulder, nausea and vomiting, and elevation in ALT, GGT, and bilirubin. Sonographic findings include gallstones. There's a positive sonographic Murphy sign. There's gallbladder wall thickening, gallbladder enlargement, pericholecystic fluid, and sludge. So here we have two images for acute cholecystitis. A sagittal, B was transverse. This patient had a positive Murphy sign. There's an inflamed gallbladder with sludge and gallstones, and the wall of the gallbladder is quite thickened. There's also some pericholecystic fluid. So here is the gallbladder wall being evaluated in a transverse image, and there's a small amount of pericholecystic fluid which you can see here on top of the gangrenous cholecystitis, which is one of the sequelae or progression of acute cholecystitis. Gangrenous cholecystitis can be a direct evolution of acute cholecystitis. And in addition to the sonographic findings of acute cholecystitis, gangrenous cholecystitis includes focal wall necrosis, bulging of the gallbladder wall, slurred membrane, ulcerative craters, perforation or rupture. And if there is a rupture, there is going to be some high morbidity, and this usually is secondary to peritonitis. A distinct gallbladder wall tear may be noted with sonography, and the gallbladder may be irregular in shape. So clinically, the patient does not always demonstrate a positive Murphy sign. And one of the differentials of this is empyema of the gallbladder, or suppurative cholecystitis, in which the gallbladder is filled with purulent material, such as pus. Although it may be difficult to diagnose sonographically, chronic infection of the gallbladder may also result in xanthogranulomatosis cholecystitis, which is characterized by asymmetrical gallbladder wall thickening. So clinically, patients would come with right upper quadrant pain, leukocytosis, elevation in ALP, ALT, GGT, fever, nausea and vomiting, pain that radiates to the shoulders. Sonographically, the patients may present with gallstones, a loss of the Murphy sign. There can be gallbladder wall thickening with a perceptive wall tear, focal wall necrosis, ulcerative craters, or the gallbladder has lost its shape. They can be sludge, they can be pericholecystic fluid. Here we have gallbladder perforation. A is longitudinal, B is transverse. In a patient with gallbladder perforation, and the defect seen on the interior wall over there is better demonstrated in the transverse section, and I suspect that is a break or a tear in the gallbladder wall, and so we would refer to this as a possible wall tear of the gallbladder. And here you can see the gallbladder has lost its typical shape. And there's some material within it. I wouldn't particularly say those are gallstones. So we can move on to emphysematous cholecystitis, and this is most often discovered in diabetic patients, and it is a form of acute cholecystitis that is caused by gas forming infection invading the gallbladder lumen, and these gas bubbles are produced by bacteria within the gallbladder, and it leads to a manifestation of dirty shadowing, or they can be reverberation or ring down artifact. And these gas bubbles may rise to the non-dependent wall of the gallbladder, producing what we call this champagne sign. So although patients with emphysematous cholecystitis may not have a positive Murphy sign, they can have certain clinical symptoms associated with acute cholecystitis: right upper quadrant pain, fever, and they might be diabetic. Sonographic findings include dirty shadowing with a reverberation or ring down artifact, and these would emanate from the gallbladder wall or the gallbladder lumen. There's a champagne sign, that is gas bubbles within the gallbladder wall, akin to the gas bubbles in champagne. This is a longitudinal sonogram of the gallbladder, and you can see these arrows show within the interior wall, secondary to an emphysematous cholecystitis. Chronic cholecystitis results from intermittent obstruction of the cystic duct by gallstones, and it results in multiple bouts of acute cholecystitis. Clinical findings include intolerance to fatty foods and a non-tender bladder. So sonographically, the gallbladder wall will appear thickened, and there may be evidence of the wall echo shadow sign. Clinically, we said with intolerance to fatty foods, and there's a non-tender gallbladder. Sonographically, the gallbladder is contracted. There is the wall echo shadow sign, the gallstones, and there's wall thickening. We can move on to an acalculous cholecystitis. These patients who present with all of the symptoms and sonographic findings of cholecystitis, except no gallstones are present. And this form of acute cholecystitis is more commonly found in children, recently hospitalized patients, or those who are immunocompromised. Clinical findings include right upper quadrant tenderness, epigastric or abdominal pain, and leukocytosis. Sonographically, you will see a positive Murphy sign, gallbladder wall thickening, sludge, peripolycystic fluid. Here we can see a striated thickened wall of the gallbladder. And there was a positive Murphy sign and fever. No gallstones were identified. We can move on to gallbladder enlargement. The gallbladder should not exceed 4 to 5 centimeters in width or 8 to 10 centimeters in length. And the transverse measurement is more indicative of gallbladder enlargement. And again, if the transverse measurement exceeds 4 centimeters in those with clinical indications of obstruction, then we should observe the biliary tract. Gallbladder enlargement can be caused by blockage of the cystic duct or other part of the biliary tree, and we may refer to this as a hydropic gallbladder. Patients may be asymptomatic or complain of epigastric pain, nausea, and vomiting. An enlarged gallbladder is often palpable on physical examination. A Courvoisier gallbladder describes the clinical detection of an enlarged, palpable gallbladder caused by a pancreatic head mass, and patients with courvoisier gallbladder also typically have painless jaundice. So sonographically, the gallbladder measures 4 to 5 centimeters in diameter, or 8 to 10 centimeters in length, and such for obstructive entities, such as cholelithiasis or pancreatic masses. A porcelain gallbladder is typically clinically silent, and it results from the calcification of the gallbladder wall, and it is characterized by the presence of an echogenic curvilinear structure within the gallbladder fossa with posterior shadowing. There is dense calcification of the gallbladder wall, and it may appear sonographically similar to the wall echo shadow sign. So gallstones are linked with a porcelain gallbladder, and patients would have calcification of the gallbladder wall. There may be a curvilinear structure within the gallbladder fossa with shadowing. There's identification of a calcified posterior wall of the gallbladder. There's a porcelain gallbladder with a wall echo shadow sign, and signs of cholecystitis or gallstones may be present. So it's important to note that a calcified posterior wall of the gallbladder helps us differentiate a porcelain gallbladder from a West sign. And with a West sign, the posterior wall is typically obscured by shadowing gallstones within the gallbladder, although many times the posterior wall will be seen with a porcelain gallbladder. Gallbladder carcinoma. Although this is the most common cancer of the biliary tract, a gallbladder carcinoma is rare, and it is thought to be caused by chronic irritation of the gallbladder wall by gallstones. So a gallbladder carcinoma may appear as a distinct, non-mobile hypoechoic mass within the lumen of the gallbladder, or as diffuse gallbladder wall thickening. It may also appear as an irregular polypoid mass that completely fills the gallbladder fossa, and it may have invaded the adjacent tissue at the time of diagnosis. Gallbladder carcinoma is suspected if a polyp or mass measures greater than 1 centimeter. If confused with tumefactive sludge, color Doppler can reveal vessels within the malignancy. And the most common metastatic disease of the gallbladder is a malignant melanoma. And just note that it is difficult to sonographically differentiate metastasis from a primary gallbladder cancer. So clinically, patients would show with weight loss that is unexplained, right upper quadrant pain, jaundice, nausea and vomiting, hepatomegaly, or possible elevation in liver function tests. Sonographic findings of the gallbladder carcinoma include a non-mobile mass within the gallbladder lumen that measures greater than 1 centimeter, diffuse or focal gallbladder wall thickening, an irregular mass that may completely fill the gallbladder fossa, or invasion of the mass into surrounding liver tissue. And this is all. Thank you.